of risk factors, including the determinants, which live very closely to the health problem, such that a change in the level of the determinants directly impact the level of the health problem in our community. We also discussed how we then identify the direct and indirect contributing factors that affect the levels of the determinants. We worked together on a number of examples. The first example was neonatal mortality. In this example, the health problem was neonatal mortality, and we identified together the determinants and the direct and indirect contributing factors of this health problem. We then did 2 additional examples in class that are not on the slides. In one example, the problem was breast cancer mortality, and again, we worked together to identify the determinants and contributing factors of that problem. And in another example, the health problem was the prevalence of unintended pregnancy in a community, and again, we worked together to identify the determinants and contributing factors of that health problem. So at that point, we talked about how we go about developing our intervention strategy by identifying those determinants that are most amenable to change, and also by developing our impact and process objectives. We concluded our discussion last week by identifying the different types of objectives that we typically develop when we are designing a program. We said that there are really 3 types of objectives. Our short-term objectives that address the future level of the contributing factors, our intermediate objectives that address the future level of the determinants of the health problem, and our long-term objectives that address the future level of the health problem itself. Okay? And we also discussed how our intervention activities will really focus on the process objectives or the short-term objectives. So for each process objective, we need to develop a work plan, also known as an action plan, that includes the different activities or tasks needed to achieve that process objective. We also agreed that once the process objectives are achieved, if we had analyzed our problem correctly for its determinants and contributing factors, the achievement of the process objectives should lead to achievement of the intermediate impact objectives, which in turn should lead to the achievement of the long-term outcome objectives. So again, I'm going over this quickly because this is all from last week. Any questions about any of the material that we discussed last week? Any clarifications needed? Anything that you're not sure about? Okay, so we will continue then our discussion this week, focusing on developing action plans for our process objectives, developing a budget for our program, and then evaluating our efforts. Okay, so at this point we are, right here where this yellow phase of the process is highlighted. Developing the work plan, developing the budget. Okay. How do we go about developing our work plans? Again, for each process objective, for each short-term objective, because our process objective is our short-term objective, we need to develop an action plan or a work plan. Okay? And this action plan should include, at minimum, 3 different components. The different activities or tasks that we will need to carry out to achieve our process objective, and then for every activity or task, we need to identify who on our team is responsible for achieving that task, and what's the time frame or the deadline by which this task should be accomplished. This information can then inform the development of our budget. Okay? So let's just brainstorm together an example. Can you guys give me one of the process objectives that we developed last week? Just pick any of the process objectives that we developed last week and read it out aloud to us. Who would like to volunteer to do that? Any of the process objectives that we drafted last week. And we drafted several for the different examples that we looked at.
There was knowledge and attitude with women to teach screening for breast cancer.
Okay, exactly. Thank you, May. So one of the process objectives was to increase the knowledge and attitudes of women 40 years of age and older, let's say in Washington County here, about breast cancer screening, okay? Again, in this case, the health problem was breast cancer mortality. We identified a lack of screening as a determinant of that problem, and then we identified the factors that contribute to lack of screening. One of those factors was the limited awareness of women of the importance of screening and the screening guidelines. Okay, so our process objective was to increase again the proportion of women 40 years of age and older in Washington County who are knowledgeable and who have positive attitudes about mammography screening. Okay, so what do we need to do? The question now becomes, okay, we've done the analysis of the problem for its risk factors. We identified a limited awareness of mammography screening as a contributing factor. We developed this process objective to address this contributing factor. Okay, so now we have to be thinking, our project team has to be thinking about what activities, what tasks we actually have to implement in order to increase women's awareness of mammography screening in our community during, this 1 to 2 year period that we have defined for our process objective. And I say 1 to 2 period because, again, typically process objectives are short-term objectives. So what are the kinds of tasks, what are the kinds of activities that you think we should be doing as a team to increase women's awareness? Talk to me. What would you do if you were designing this program? Yes.
Reach out to the media and create kind of educational materials for women about mammography.
So excellent. Create educational, materials about mammography, okay? Or perhaps, adapt existing materials to our population if they are there. And you said reach out to the media. What are we thinking about in terms of media?
Probably local radio stations or community television programming, okay, to raise awareness about maybe screenings we're hosting.
Okay, great. So we can do radio ads, we can do TV ads. What other types of media activities can we also implement if we want to expand the reach of our program?
Social media.
Social media, help me understand that, please.
Like making Facebook ads or groups or Twitter, something like that.
Exactly. So we can now leverage, right, the power of social media to disseminate our educational materials. Other channels for disseminating educational materials?
The walk, like the regular, like Alzheimer's walk or cancer's walk.
Exactly, organize a community walk
yeah.
to raise awareness of this topic. Wonderful. Other thoughts? Where else might we, again, promote our materials, for example, in addition to social media and TV, radio?
There are,
Yes.
in our country, actually, we hold some camps, like there are some camps, and we tell the people, we give them the pamphlets to them and tell them that they should be coming for a free checkup or free.
Excellent. So organize camps or health fairs where we disseminate this information. Wonderful. We can also use billboards, right, on major roads. We can put our flyers, posters inside public transportation, on buses or other types of public transportation. We can disseminate our educational materials to the health clinics and the doctors' offices so they can distribute them to their populations as well. So there are really different mechanisms, and we need to identify those mechanisms that are going to be most effective with our priority population, right? So who's going to do all this work? Who's going to do all this work? We need people, right?
Yeah.
We need staff, right? We need to hire typically staff, and this involves creating job descriptions, advertising those positions, identifying qualified candidates, interviewing them, hiring them, training them, okay? So typically one of our first tasks or activities for any action plan should be our personnel, making sure that we have the people on board that we need, okay? So we have to think as a team, who do we need? Do we need a program director? Do we need a project coordinator? Do we need health educators, nurses, design specialists, media specialists, right? Evaluation staff. We have to identify our personnel needs. And again, one of our first tasks will be hiring and training those people so they are on board and then can engage in creating our media campaign or other educational efforts. Okay? So again, each of those activities that we talked about, the staff hiring, creating the educational materials, the social media coordinator, the TV, radio campaign, all of those are specific activities, and each one of them must be listed in our work plan. And a member of our team identified as the person responsible, and again, a time frame for that activity identified. Why is it important to identify the person responsible for each activity?
Accountability.
Accountability, exactly. We need a champion for that effort. Okay, we need a leader to make sure that things get done. So this is an example of a measles immunization program. The objective here is to achieve a 95% immunization rate among 2 to 3 year old children in Washington County, Tennessee by 2018. The baseline was 85% in 2014. Now let me ask you, is this a SMART objective based on what we discussed last week? Okay, again, those are the kinds of objectives that we're hoping you will develop for phase 2 of your project. Okay, something as clear and as clean as what you have in front of you. Okay? What are some of the activities, the key activities that we will need to implement in order to achieve these objectives? Public education, provider education, community outreach, the actual vaccines or shots, record keeping, and so on. Where did we come up with this objective? Again, this is very important when you're developing objectives. As much as we love your educated guesses, objectives should not be based on your educated guesses. Okay, as we explained last week, they should be based on the literature, they should be based on guidelines. Okay? One good place to start is Healthy People 2020, which contains specific objectives in different areas. Also, a couple of resources that are very important for you as you work on your project, and please write those down and refer to them. There's something called the Community Guide, okay, which is short for the Guide to Community Preventive Services. Okay, the Community Guide, short for the Guide to Community Preventive Services. It's available online, okay? This is a very important guide that presents evidence-based interventions for community initiatives. Okay, make sure that you are consulting this guide when you are designing your program. If your program is clinical based, okay, if you're proposing to do an intervention that is clinical in nature, okay, like increasing hypertension screening rates or increasing counseling around cholesterol, for example. Make sure that you check the Guide to Clinical Preventive Services. Okay? So those two guides are complementary documents. One focuses on community-based, population-wide initiatives, and the other focuses on clinical-based initiatives. The Community Guide to the Guide to Community Preventive Services and the Guide to Clinical Services. Okay, again, please make sure that you check both of those documents, and they are listed on one of the slides here. And there are links to them also from the course website. So if you go to this module under resources, you will find links to those documents. So how do we present our work plan? How do we present our action plan? There are really different formats, different templates for presenting your work plan. There is not a right or wrong way. Again, there are different formats. Two commonly used formats are the key activity chart and the Gantt chart. The key activity chart is what you will be using in phase 2 of the project. Again, they're just examples of how you present your work plan. The Gantt chart is also commonly used, and it's a matrix that shows the different activities and the time periods for each one of them. So let me show you an example of a Gantt chart. Okay. So this is a proposal that we developed, last year. that was funded, and we're currently working on this project. This is a 6-year, very large project aimed at reducing unintended pregnancy by expanding access to all types of contraception. As you can see, this is a 6-year initiative, okay, 2017, 2018, 19, 20, 21, 22, and then the first quarter of 2023. And the way this chart was developed was based on quarters. So every column in this chart is a quarter or a 3-month period. Okay, follow just the mouse. So this is, for example, here where the mouse is. This is the first. This column, that's the first quarter of 2017, January, February, March. The second column is the second quarter of 2017, April, May, June. The third column is the third quarter of 2017, and so on. So the 1, 2, 3, 4 are the 4 quarters of 2017. Then we have another set of 1, 2, 3, 4, which are the quarters of 2018. We did this by quarters, not by month, simply because it's, again, a 6-year project. And from a management and presentation style, doing it monthly is just not feasible. Now what you have in the rows are the different activities or tasks that need to be implemented. So each row displays a different activity or task, and each column again displays 1 quarter of the year. And the shading in those cells indicate the time frame for each activity. Okay, so the first activity listed here is going to occur, or the plan is for that activity to occur during the first 3 quarters of 2017. Okay, so this is one way, again, of presenting your work plan. And again, this is a very large project, so there are really lots of activities here, everything related to getting IRB approvals, data collection. You can clearly see what those activities are, and you can clearly see when each activity is planned to begin and to end. Some activities occur throughout the life of the project, whereas other activities are short in duration. So again, this is just one format. For your project, you're going to do what we call the key activity chart. Which basically has 3 columns. So we're, again, keeping it simple. And then as many rows as needed to list the activities for each process objective. So in the first column, you will include the activity or the task. The second column will be the person responsible, and the third column will be the time frame. Okay, and you will do this for each of the 2 process objectives. So you will have a work plan for process objective 1, and you will have another work plan for process objective 2. And again, identify and hire program staff, for example, design educational campaign, etc. And you'll identify not the name, but the position responsible. Again, this can be your program director, it can be your health educator, your nurse, your media specialist, and the time frame. Okay. Any questions, folks, about work plans?
So we don't have to put the budgets.
The budget will be next. You will do one budget for everything, yes. So the budget we will discuss next, and the budget will be informed again by those activities. Yes, sir.
I would just like to know, it's a kind of a personal question. What's the importance of budgeting, or what's the importance of delving into how to create a budget to a public health professional? I feel personally, apart from the area of accountability, which we have to account for everything we are doing, I feel public health professionals should focus more on getting the things done for the community. So why do we have to learn budgeting? Why do we have to know how to put this in place as a public health professional?
Thank you. That's an excellent question, and the short answer to that is really because we cannot do anything for our community if we don't have the resources that we need to do that work. Okay. So again, in this example, that I had shared with you, we had to apply for funding. Okay, so funding is increasingly, not just awarded. Public health professionals have to apply to foundations, to government agencies, and to other entities for funding. And when you're applying, you have to include your problem statement, your objectives, your work plans, your budget, and your evaluation plans. So effectively, what you're doing for the project, phase 2 of the project, is a proposal. When it's all said and done, it's a proposal to develop a program plan. And there is no funding agency that will review your proposal if it does not include all of those elements. Also, public health professionals, in addition to program planning, I think many of you at some point, hope to become program managers, health department directors, hospital administrators. So many of our students and many public health professionals in general, really, we're preparing you for executive level positions in the public sector as well as in the private sector. And as an executive, financial matters, including budgeting, are an important, function of everything that we do. So I hope that answers your question. Okay, thank you. Any other questions related to work plans? Okay, so now that we have our work plans in place, we can develop our budget. Okay, why? Because again, the budget should reflect the different activities and the different personnel needs that are outlined in our work plan. And I hope it's becoming clear to you why you really need to start working on your projects sooner rather than later, okay? Because it's a sequential process. I mean, even if you have a member of your team who's gonna be leading the budgeting effort, that member cannot do anything until the objectives and the work plans are developed, right? And if you have a person who's gonna be leading the evaluation piece, that person cannot do anything until the objectives are developed, because they're gonna be designing an evaluation plan specifically to assess achievement of those objectives, okay? So please keep that in mind as you develop your timeline for working on your project. Okay, so the next thing again that we're gonna discuss is budgeting. And again, typically any budget is gonna include two main sections, two main parts. Anyone wants to guess what those are? What are the two main buckets in any budget? Personnel
Equipment.
and non-personnel. That's it. That's it, right? Anyway, as simple as that. The two main buckets are your personnel expenses and your non-personnel expenses. So everything else that you see, here on bullets 3 and on, equipment, supplies, communication costs, commodities, travel, space, all of that falls under non-personnel expenses, okay? So the common budget items, again, are listed on this slide. This is not an exhaustive list, okay? This is a sampling, again, of the most common items that you will find in a budget. The personnel are the people who are gonna be working on that project, okay? As a department, I have my personnel, I have my faculty, my staff, my graduate assistants, my undergraduate student workers, those are my personnel in my department, okay? As a project, the unintended pregnancy project that I mentioned, I also have a team of personnel, okay, who are working on that project separate from the department with their own budget. How do we budget for personnel? We have to include both the salary that we're going to be paying them as well as the cost of their benefits. What are benefits? Health insurance,
401ks.
retirement plans or 401ks. 401ks if you're in the private sector, 403b plans if you're in the public sector. What else falls under fringe benefits?
Allowances like housing.
We could offer allowances for housing. So we heard health insurance, we heard retirement benefits. What else?
Would include like paid travel.
So paid travel is very important, but will go typically under travel. What other sick or paid leave? Wonderful. What other benefits employees typically get? Okay. A lot of organizations actually offer subsidized disability insurance, subsidized life insurance, right? In addition to health and dental insurance, again, sick leave, tuition for children, yes. So at ETSU here, for example, all faculty and staff are eligible for, the university will cover 50% of the tuition of our children. So that is a benefit of employment, yes. So the benefit package can vary, right, depending on organizations. Typically, larger organizations tend to offer more comprehensive benefits, typically, relative to small organizations. How do we calculate benefits for budgeting purposes?
Use previous.
We calculate them as a percentage of salary. Okay, what does that mean? So let's take a look at this example in front of us. This is a very, very simple example of a personnel budget for a relatively, small program. In this example, based on our work plans, we identified, that we need a program director, we need 2 health educators, 2 nurses, 1 physician, 1 program evaluator, 1 secretary, and a consultant. Okay? So how do we go about developing the budget for those positions? Okay? So first step, we identify what those positions are, again, based on the work plan. We identify how many positions we need in each category and the percent effort that we need each person to work on the project. Okay? Some people are going to be working full-time on our proposed program or initiative, whereas some people will be working part-time on our initiative. Okay? So I'll give you an example, again, of our Choose Well or Unintended Pregnancy project. Our director, Dr. Mike Smith, is 90% effort on the study. Okay? I am 35% of the study, okay, as the principal investigator. Okay? Dr. Beatty, as a project leader, is 35% on the study. Okay? So we have to determine, every individual, again, what percent of their time effort is going to need to be allocated. Our secretary, Anne Marie, is 100% on the study. One of our program managers, Natalie, is 100% on the study. Okay? So our contribution varies. Again, depending on the work plan and what the role of each one of us is going to be. Okay? Once we figured out the percent effort of each staffer, we identify the base salary for them. Where does the base salary come from? If we are a large organization like ETSU, for example, we go to our human resources department. And they work with us to identify appropriate salaries for our people. Okay? We can also look at the market salaries for those positions. I mean, you can search online and identify in your market, in your area, okay, what is the typical salary or the salary range, for example, for a master's prepared director or a doctoral prepared director, okay? Or what is the typical salary for a secretary with a high school degree. But you have to look them up for your own market, okay? Because salaries, for example, in New York City or in Los Angeles, for the same position with the same qualifications are going to be significantly higher than salaries in Johnson City. Why is that?
Cost of living.
Because of cost of living, okay? So in those big cities, the cost of living is significantly higher. Okay, we need to pay people more. Next, we identify the program salary. The program salary is what proportion of their salary is going to be allocated or paid by our program. So if a position is 100% allocated to the program, then the program should pay all of their salary, right? Okay. 100% times 60,000, then we put 60,000 in the cell. However, if a person is only allocating 20% of their time to the project, then the project should only pay for 20% of their time, okay? Which is 0.2 times 52,000, okay? So this is how we complete this column. Once we have identified the salary that the program will pay for each position, we can calculate the fringe benefits. Fringe benefits are calculated as a percentage of the program salary. Okay. So here at ETSU, for example, we know from our HR office and our grants people that typically the fringe benefits for an ETSU employee cost the university about 35% of their salary. Okay. So for the university to offer me health insurance and life insurance and sick leave pay and tuition benefits for my kids, etc., that costs the university, that package costs the university about 35% of my salary. They're not paying me that in cash, but the university is spending that kind of money in order to purchase those benefits that they then provide me with. Okay? But for budgeting purposes, again, we determine the cost of the benefits to the institution or to the program as a percent of salary. That percent can range typically between 25% to 35%, again, based on how comprehensive, how generous the benefit package is that our employer offers. Okay? So in this example, which you guys are going to be doing in just a minute here, assume that fringe benefits are 30% of program salary. Okay? Then the total cost of the director to the program will be her program salary plus the cost of the benefits that she will receive. Okay? And our total personnel budget for year one will simply become the summation of all of those figures that appear in the total column. Okay? So why don't you now please work with your neighbor to complete or to replace all of those question marks that are in this chart with dollar figures.
Is it 30% for the benefits?
Okay, so let's go ahead and complete this chart together. Okay, and I'm gonna start here in the front, and every person is gonna give me a figure, and we're gonna go around. Okay, so we're gonna start with Sylvester. Program salary for our director, please.
That's 60,000.
That's 60,000 because again, their 100% effort is allocated to our program. If anyone is not sure about how each of those figures are calculated, please speak up now. Program salary for the educator, Ireti?
24,000 for the two of them. No. Sorry. 40,000. Oh, 80,000 for the two of them. Sorry.
80,000 for the two of them,
Yeah.
right? 40,000 for one, 80,000 for two.
What?
So we are calculating it for, oh, yeah.
No one even looked at that section.
Who said it was right?
Okay, folks, let's please hear each other out.
So
For the nurses,
one position will be 50,000, and then two positions will be 100,000.
okay, 100,000 for two positions. If you're not sure, speak up now, please. May, the program salary for the physician,
It's 24,000.
24,000. How did you arrive at that figure, please?
20% times 120,000.
Okay, so the total salary or base salary of the physician is 120,000 per year, but since she is only working 20% on our program or 1 day a week, our program will only be paying 24,000 of her salary. The rest of her salary, I guess, will be paid by the hospital or the clinic or wherever she's working that 80%. Okay? Program salary for our evaluator, please. 10,400. Program salary for our secretary, sir.
24,000.
25,000, right? The secretary is allocating 100% of her effort to our program, so our program will pay her salary in full. Okay? And then the consultant is being 10% of the time of the consultant is an in-kind contribution by the Heart Association. So our program is not paying for that 10%. But we should note, either here or in the justification that this is an in-kind contribution. Okay, benefits. So again, in our example, we are assuming that benefits are calculated at 30% of program salary to cover the costs of insurance and other benefits for our employees. So what is the cost of the benefit package that the director will receive?
18,000.
18,000, and I have a question in the back.
Okay, why is the program salary for the director 60,000 and the other one double?
Why is the program salary for the director 60,000? That's the question. You got your answer? Okay. Are you sure? Okay. So how did you, before you leave to the bathroom, please, how did you calculate, how did she calculate the 18,000? How did she get that figure? 60,000 times 0.3, okay? The cost of the benefits package for the educators.
24,000.
24,000, so that's 80,000 times 0.3. Did everyone get this figure? So 12,000 cost of benefits for each nurse, educator, 24,000 for both. Cost of the benefits for the nurses?
30,000.
30,000. 15,000 for each, 30,000 for both. Again, that's not money that the nurses will be receiving. That's how much it will cost our program to provide them with the benefits. Fringe benefits for the physician?
7,200.
7,200. Now here it's important to note that typically in real life, part-time employees are not eligible for benefits typically, okay? But for the sake of this example, as an illustration, we are calculating benefits for them. Benefits for the evaluator?
3120.
3120, okay. Where are we in the... And for the secretary? $7,500. Okay. Is anyone not sure how we arrived at those figures? Okay, let's go back to our terms. So what is the total compensation package that the director will receive? 78,000. Again, of that, 60,000 will be paid in salary and 18,000 will be used to cover the costs of the benefits. The total compensation package for the educators,
104,000.
104,000 for both of them, or 52,000 for each. Nurses,
130,000.
130,000, or 65,000 for each. Physician,
31,200.
31,200. Evaluator,
13,520.
13,520. Secretary,
32,500.
32,500. And then what is the total personnel budget for this program for year one? 389.
I don't know what's
220. Did everyone get this figure?
Yep.
So again, this is how much we will budget for personnel expenses for year one. Any questions? Any questions, folks? No? Clear? Crystal? You're gonna be able to do this for your project? Okay. Because if you can't, Dr. Beatty will come after me. Okay, so now let's take a look at an example of the non-personnel budget for the first year of our program. Again, this includes some of the key items. It's not exhaustive. It's actually quite simple for presentation purposes. Travel is usually a key component of the non-personnel budget. Travel is typically broken down into in-state travel and out-of-state travel. In-state travel is simply when we're traveling for work within our state, within Tennessee. Okay? When we're traveling within Tennessee, let's say from Johnson City to Nashville, the capital city, which we do all the time, or from Kingsport to Knoxville for meetings with our partners, or from Kingsport to, from Johnson City to Kingsport to meet with the health department folks there, we calculate travel based on mileage. Okay? So we estimate the average miles per round trip to and from our main location, which is Johnson City. We estimate the number of trips that our staff will be making each year. And we know, okay, what is the rate per mile. This is published information, okay, that's available online. Okay? The current, per mile rate. So then we calculate in-state travel as the number of trips multiplied by the number of miles per round trip multiplied by the rate per mile. So again, if we know, for example, our program director is going to make 4 trips to Nashville to meet with the state legislators, 1 every quarter, okay? Then we get on MapQuest or whatever app we're using. We determine the miles between Johnson City and Nashville round the trip. Okay, we know he's gonna be making 4 trips. We know the miles, they're available, and the rate. Then we think about the educators, what kind of travel they're gonna be doing, and we estimate it the same way. Out-of-state travel, however, is typically calculated or budgeted for differently, okay, based on trip or meeting or event that the staff will go to, okay. The estimate per trip or per meeting again can vary. A typical estimate is $1,500 per trip to cover the cost of the plane, the airplane ticket, the hotel accommodation, ground transportation, and per diem. Okay, so in budgets, typically, funding agencies will accept anywhere between $1,500 to $2,000 per out-of-state trip. Okay, so you don't have to figure out, the hotel and the airline ticket, and you can bundle it up like this. So again, if your director is gonna go to one professional meeting, and if your evaluator is gonna go to another professional meeting, you determine the number of out-of-state trips that they will be making and multiply it by the average per trip. Yes.
So does this figure go into the per diem?
Into the per diem?
Yeah, you give.
The per diem is included in this figure. The per diem is included in this total. So the total includes, the airline ticket, let's say $400 or $500, right? 2 nights at a hotel for $200. The per diem, which is typically between $40 to $60 per day, okay? And then ground transportation, cabs, from the airport to the meeting location, taxes. So this figure that you put here again is the bundle that includes all of that.
So they come back to reconcile.
Mm-hmm.
They reconcile for the cost of transportation.
Yes. When you come back from your trip, you submit all of those receipts and you get reimbursed by your organization. The total may not come, maybe a little less, a little bit more, but for budgeting purposes, this will be your best estimate. Okay. Communication. So communication is the cost of telephone lines, internet charges, and other types of communication. Again, you're going to estimate that to the best of your ability. You have to determine what equipment you're going to need. Okay? You need computers for your staff. You need printers. You need data projectors to give your presentations. This is office equipment. This is not including medical equipment. So you estimate the number. First you estimate what types of equipment you need, the number of each unit, and the average cost of each, and then you total it. Office supplies is going to be everything from pens, pencils, papers, folders, printer cartridges, etc. Again, this is typically for budgeting purposes bundled up and estimated at somewhere between $500 to $1,000 per full-time employee per year. Okay, so you go to your personnel budget, you see how many employees you have there, full-time employees, and you multiply that number with your supply estimate per person. So you don't have to figure out how every pencil will cost you or what each piece of paper will cost you. You can use a budget. Printing is the cost of printing your flyers, your posters, your educational materials, your reports, your presentations, etc. And again, you have to estimate that. Okay? So this is not an exhaustive list. Okay? I can share with you, for example, again, a recent budget that I did, which was pages and pages of this. We had to include the cost of hiring people, the cost of advertising the positions, the cost of training, the cost. But again, for a small program, those will be the key categories. So why don't you please take a minute and again, with your partner, replace those question marks with dollar figures.
I'll have a question. The devices.
Yes. Who had a question?
Would you mean the two PCs and printers with the technically 4 items, or is it just? So there's 2? Okay.
Okay, so in-state travel, where did we get with the term? Where are we? Okay, Conley. Yes.
540.
Okay, 540. How did you calculate that, sir?
Number of miles per round.
Give me the actual numbers that you multiplied.
20 times 50
Mm-hmm.
times 0.54.
20 times 50 times 0.54 equal
540.
520? 40. Okay,
Yes, next two.
thank you. Manul.
3,000.
So 3,000 for out of state travel, 2 trips at 1,500 each. Equipment. Ladies,
Oh,
equipment.
yes. 7,900?
How did you get at that number, please?
So 2 PCs, that's 3,000 plus 2 laptops, that's 2,000 plus another 2,000 plus 600 plus 300.
Okay, everyone got that?
Yes.
Okay. Office supplies.
4,500.
And how did you get that figure, please?
9 employees times 500.
So let's look here. How many full-time employees do we have? 6 full-time employees, right? One.
Wait, how did you get the 6?
2 educators, 2 nurses, and 1 secretary. 6 full-time employees.
Oh, okay. We just thought they were all full time. So just kidding.
Times 500 each is 3,000. Okay? So what is our total non-personnel budget for year 1? 21,640. Okay? Everyone feels that they know how we arrived at this figure? Okay. So now we are gonna add the personnel and the non-personnel budget. 389,220 plus 21,640 will give us our budget for year 1. What's that figure? 410,
860.
860. Okay. We are going to assume, again for presentation purposes, that our personnel and non-personnel needs for year 2 of our program will be similar to those for year 1. So to calculate our year 2 budget, we are going to simply increase our year 1 budget by the inflation rate, which is typically 3 to 4% per year. Okay? So our year 2 budget then is what?
427,294.
427
294.
427,
294.
And 47.
Yeah, 0.4.
So that's our 410,860 times 1.04, right? Increasing it by 4% to account for inflation. Again, this assumes that the project activities and the personnel and non-personnel needs are the same in both years. That is typically not the case. Okay, typically not the case. Because your activities will vary from one year to the other, and as such, your personnel and non-personnel needs will also vary. So for this 6-year project that I showed you the plan for, our budget is different for each year and had to be calculated for each year separately based on what activities we had proposed in that big chart for each year. Okay? But again, here for simplicity, we're assuming similar expenses. So if this is a 2-year program, then the total budget for both years is 838,154. Okay? So one more time, I will ask, does everyone feel comfortable with how we arrived at those figures? Okay? For your project, you will be developing a budget for year 1. Okay? It's not going to be a 1-year project, obviously, because you're going to have, again, short-term, intermediate-term, and long-term objectives. But for the sake of the project, you will just develop a personnel and non-personnel budget for year 1. Okay? Any questions before we go to break? Is that a question or is that yawning? Okay, why don't we guys have a short 5-minute break and reconvene here at 2:40. Okay, so at this point in our program management cycle, we have completed developing our work plan and our budget, and we are ready to discuss our evaluation plan. So program evaluation. Okay, so this will be a crash course, 1-hour crash course. Again, we teach semester-long courses on program evaluation. If you're interested in learning more, we do have those opportunities available to you. This is an increasingly important aspect of program management. Again, hardly any funding agency at this point will support a program or a policy proposal that does not include a rigorous evaluation component. Okay, so let's start by highlighting the 3 major types of program evaluation, all of which are important and again should be included in your program proposal. all three types because they have different purposes. The formative evaluation, the process evaluation, and the impact evaluation. So we will define each one of them and identify its primary purpose. Again, in this introductory course, we really don't go into the specific methods of each of those evaluations, except perhaps for impact evaluation. But for everyone in public health, it's important that at least we understand what those evaluation types are and what's the purpose of each one of them. So formative evaluation focuses on evaluating the development of your program, including the quality of the materials and messages, and the keywords in this definition are underlined for you, okay? So let's think back to the beginning of class today when we were talking about creating materials to increase women's awareness about breast cancer screening, right? We talked about developing TV commercials, radio spots, billboards, right? Social media messages. Okay. What formative evaluation does is it assesses the appropriateness and the quality of each and every material or message that we develop. Okay? So let's say, our team, our project team, put together a media campaign. They designed, flyers. They designed brochures, billboards. How do we know that those are appropriate and relevant to the population that we want to serve? Okay? We know that by conducting the formative evaluation. So we bring together members of the population. If our target population is women 40 years of age and older in Washington County, then we identify, 2 or 3 groups of women in this age range, and we invite them, to come here to campus, and we share with them the draft materials that we develop, and we seek their input about those materials. There are actually questions that we can ask, standard questions in formative evaluation. We assess the readability of the materials. Are the materials developed at a reading level that our priority population can read and understand, given their levels of health literacy? Yes?
Can we use a formative evaluation as a way to ensure buy-in from community members during
Sure.
our stakeholder process?
Sure, definitely, that's an excellent point. We ask them about the messages itself. Are they culturally appropriate? Okay. We ask them to interpret the messages and the materials using their own words to see if they are understanding what we intend for this message to deliver. So can you tell me in your own words what this flyer is about? Can you tell me in your own words what is the key message in this brochure? Okay? So we ask them open-ended questions. Is there anything in this TV spot that you find offensive? Okay. So this is, again, a very important piece of developing your program. We then revise and refine our materials and messages based on the input that we get from our focus groups or discussions with members of our population. And then we test again the next version to see if there are additional refinements that are needed before we finalize everything. Now let me ask you something. What if we are using materials and messages that were already developed by the American Cancer Society or by the Susan Komen Breast Cancer Foundation? Do we need to go through formative evaluation?
Yes.
Yes, why?
Because of the group of people you're targeting. The community you're targeting is not just the general, it's a specific group of people. So it doesn't matter if it fits others, it might not fit them.
Exactly. So even if we are using materials and messages that have been developed, we want to test them with members of our priority population to assess, again, their relevance, their appropriateness for that population, and adapt them as needed. Okay? We use the same process when we are developing survey questionnaires. Excuse me. We're currently doing a lot of survey development for our research work here. So we draft, those surveys and then we test them with members of the population, again, to see are they understanding the questions, are the questions flowing well, how long does it take them to complete the survey, and so on. Any questions about formative evaluation? Okay. So now let me ask you this, if you get a question on an exam or something like that, hint, that says evaluation starts after the program is implemented. That's false, right? So evaluation really should start before the program is implemented. Okay, that's a common misconception. If you wait to start your evaluation until after the program is implemented, you're too late. Okay. Process evaluation. Process evaluation has a different focus. Now we're starting to implement the program. Okay, we've developed the materials, the messages, we've tested them, we've finalized them, and we're rolling things out. We're in the implementation phase. Process evaluation asks the question, are we doing things right? Meaning, are we implementing our program activities consistent with our work plan and within our budget? Okay, so this is, in a way, you can think of process evaluation as an internal audit, okay, where the program leaders, the director or the manager, they're really checking on an ongoing basis, okay, whether, again, those activities defined in the work plans are being implemented at the right time and within the proposed budget. And you have to do this on an ongoing basis, monthly perhaps, or more frequently, to make sure that you're staying on track. Because you don't want to get to the end of the year and then you realize, oh wow, we forgot this major activity that was in our work plan. Or we are significantly delayed in implementing this other activity, which is going to put us behind in terms of our work plan for year 2. Okay? So process evaluation, again, assesses the process of implementing the program activities relative to what was included in the work plan and the budget. If those activities are implemented as planned, then again, we should be able to answer the question, were the process objectives or the short-term objectives achieved? Did we do things right? Did we implement activities as planned? Okay. So the process evaluation should start when? As soon as the implementation starts, right? Concurrent with the implementation. impact evaluation. The third major type of evaluation. This is also known as effectiveness evaluation or as summative evaluation. So those terms are used interchangeably. Okay? Just as the name implies, impact evaluation assesses the impact and or outcome of the program. Okay? So did you achieve your impact objectives and your outcome objectives? Yes or no? Why or why not? So the key question that we're asking here, did we do the right things? You notice with process evaluation, we ask, did we do things right? Did we implement activities as planned? Here we ask, did we do the right things? Meaning, did we address the right determinants and contributing factors? Because again, if we address the right determinants and contributing factors, then achievement of the process objectives should lead to achievement of the impact and outcome objectives like we discussed last week. So how do we go about conducting those evaluations? Okay, so give me an example, please, of an impact or an outcome objective that we developed last week. Any example? Could be related to any of the three health problems that we focused on last week: neonatal mortality or breast cancer mortality or
Low birth weight.
low birth weight. Okay, what was our objective for low birth weight?
Decrease the number of mothers with babies born below a certain threshold.
So for low birth weight, and this was one of our determinants for neonatal mortality, right? Our objective was to,
Reduce smoking, tobacco use.
for low birth weight, our objective was to decrease the low birth weight rate, right? Which is the proportion of infants born, newborns born with a weight of what? What's the cutoff to consider low birth weight?
Less than 15.
1500 grams, exactly. So to decrease the proportion of newborns who weigh less than 1500 grams, decrease the low birth weight rate from the current baseline, which is what?
Like 45%.
So a rate is typically, per 1,000, right? Births. So let's just say, okay, 50, we're just hypothetical, 50 per 1,000 births in what year? What's our baseline year? We are unlikely to have the 2017 data in 2017. So again, if we say if we're lucky, probably 2015. Decrease the low birth weight rate where? Where is in the state of Tennessee? We're gonna try to hit the whole state. That's pretty ambitious. Okay, from 50,000 in 2015 to It will be helpful if I can type, right? From 50,000, from 50 per 1,000 in 2015 to
20.
20. No,
10.
you can't bring 50 to 20.
40.
Even if you have 10 years, probably, right? That would be overly ambitious, which means you're setting yourself up to fail. Thank you. Don't do that in your project. to, okay, 40 per 1,000 by
2020, 2025.
Okay, this is your intermediate objective, right? You said intermediate objective, what is the typical time frame for the intermediate objective? Okay, so by, this is 2017 now, 2022. Okay, see how it's all coming together? Okay, that's stuff that we talked about. Means something. Okay, now, how do we go about evaluating this? Let's say this is 2020 today, December 2022, excuse me. How do we determine if we have achieved our objective or not?
We measure the low birth weight rate.
Hmm?
We measure the low birth weight rate.
We measure the low birth weight rate. That's available for us through existing surveillance systems, right? So it's secondary data that we can track, right?
We also try to see how much of that was affected by our program.
Okay, we try to see how much of that was affected by our program. So let's say this is 2022, okay, and we obtain the low birth weight in Tennessee from the surveillance systems, and it is 40 per 10,000 per 1,000. And we compare that to 2015 when it was 50 per 1,000. Okay, so we have two observations in this case, right? We have our first observation at baseline, observation 1, and then we have our second observation at the end of the program. O1 is our baseline observation, O2 is our follow-up observation in 2022. And between those two observations, we implemented our initiative, and in evaluation terminology, the initiative is represented by the letter X, right? And this is all in the state of Tennessee, okay? Which in this case is our experimental or intervention state. So what can we conclude? We met our objective, okay?
What does X represent?
X represents the program, the initiative, the interventions that we implemented during this time period. Again, what was in our work plans to achieve our process objectives. So can we conclude that we met our objective, or that our objective was, or that the objective was met?
The objective was met.
The objective was met, right? But we can't really say that we met it. We can't really attribute this change to our program.
That's right.
Why?
There's no comparison.
Because there's no comparison group, exactly. So we really don't know whether this change from 50 to 40 was because of our program or because of other policies or programs or initiatives that were occurring in the state of Tennessee during this time period through the March of Dimes or through funding from the Tennessee Department of Health or other entities. Okay? This design, folks, where you just have your experimental group, meaning the group that's receiving the intervention, and you collect 2 data points before and after the intervention X. This design is known as the one group, pre-test, post-test. Okay? One group, again, because we're only including our intervention or experimental group in the study. We have one pre-test or pre-intervention observation, and we have one post-test or a follow-up observation. This is a non-experimental design, okay? Because again, it does not include a comparison group and it does not include randomization, and it's actually one of the weakest evaluation designs. Mainly because it does not allow us to control for what is known as historical bias, history bias. History bias is the chance, the probability, the bias that occurs when some other initiative, policy or program occurs while your initiative is going on and affects your outcome. So again, what we can say here, we can say, yes, the low birth weight rate decreased in Tennessee from 50 per 1,000 to 40 per 1,000, but we really cannot attribute this decline to our X. Because it's possible that there are other X's. Maybe there's a national program that occurred across all states that affected low birth weight rates. Okay? So how can we account for that? How can we improve on this design?
Control in place, a randomization.
By including a comparison group or by randomization. Okay? Is randomization possible in this case if our target population is the whole state? If we're doing a mass media campaign across the state, right? It's reaching everyone in the state. Whether it's a social media campaign or a TV campaign.
Some of those campaigns can be targeted, even through social media or TV campaign.
Okay.
So, can we randomize?
We can randomize and do a targeted campaign. It will be really difficult to control for it because let's say I'm here in Johnson City today, but tomorrow I'm in Nashville. I'm gonna see that billboard there. I'm gonna listen to that radio there. So you're gonna have a lot of contamination when you're doing mass media campaigns and trying to randomize. There's also an ethical consideration. If we're implementing evidence-based interventions that are known to reduce low birth weight rate in our state, we really ethically, morally, we cannot deny those interventions to certain groups in the state. So in public health research, again, while randomization is the gold standard, okay, for ethical reasons and sometimes for logistical reasons, it's not an option. So our best bet in that case would be to include a comparison group, okay, that is similar in characteristics to our intervention group.
Like match with another state?
Like match with another state, exactly. Yes.
Can't they be acting as their own controls? Like we can take it at more intervals of times, like the first time and again after another 3 months again, so that they can act as their own controls.
We can do that if we do an interrupted design. Yes, over time. That's one option. Again, from a funding agency standpoint, it's difficult to justify, sometimes an interrupted design. They really want to see an impact as soon as possible. But that's an interrupted design would be an option, again, if it's acceptable to the population and to our funders. So how do we, if we're gonna, yes?
So for the effectiveness evaluation, do different methodology relate to different contexts of public health?
Yes.
So, like if we're writing a grant to implement in our community, like the one group pre-test, post-test would that be an acceptable methodology?
So when you're writing, thank you for that question, it's a great question. When you're writing a proposal, you're gonna want to try to select the best evaluation design to answer your particular questions and in your particular context at a reasonable cost. Okay? So this design, the one group pre-test, post-test, for example, would be appropriate to evaluate, let's say, your process objective. That's your short-term objective. This design, however, is unlikely to be appropriate to evaluate your impact or outcome objectives that are long-term objectives. Because again, other factors in the environment are more likely to occur the longer the time period. So what you need to understand is you need to know what those designs are, the different designs, and what are the pros and cons of each, so you can select the ones that are most appropriate, again, as you mentioned, for your context and for your objectives. So for your process objectives, again, for your short-term objectives, this will be fine because it's easy, it's simple, and it's inexpensive. Okay? But for your long-term objectives, you would want to use a stronger design that produces more valid findings. Okay? So we can improve on this design by, again, adding a comparison state. Yes, sir?
We talked about adding a comparison state that's like using individuals from a different state, for instance. But we're still talking about using something like mass media campaign. So, for instance, how do we know that they're not going to be exposed to that? In this day and age, mass media campaign goes really far. It could be on YouTube, it could go viral. So, how do you make sure our controls don't get that if you're going to use controls there?
Yeah, so that's an excellent question. I mean, there's always that possibility of contamination. You try to limit it, as much as possible by selecting perhaps a state that's, again, similar in characteristics to Tennessee in the southeast region, but perhaps not within very close proximity to the state of Tennessee. So I'll give you an example from our work, for example, currently. Our experimental state, our intervention state is South Carolina. Okay? We selected as the comparison state for South Carolina the state of Alabama. Okay? we looked at other possibilities. We looked at Tennessee, we looked at Georgia, we looked at North Carolina. We really looked at all of the states that are in the region here. Some of those states, their health outcomes, their unintended pregnancy rates were significantly better than South Carolina at baseline. So we did not want to do that because we don't want to start with apples and oranges. Okay? We want them equivalent at baseline. Okay? We also selected Alabama because it does not share a border with South Carolina, which helps decrease the possibility of contamination. So the two states, South Carolina and Alabama, have similar population sizes, similar demographics, similar rates of teen pregnancy and unintended pregnancy at baseline, but they don't share a border. So that made, they're both in the southeast region, so they have similar cultural context, political views. They don't share a border, so that made Alabama a better option than, say, Georgia or Tennessee or Mississippi. So if we do that, then if we add our comparison state here, then what we need to do is we need to also collect the low birth weight rate in the comparison state at baseline. I don't want to cooperate. Okay. And also collect the low birth weight rate in the comparison state in 2020. So now we have 4 observations. We have a baseline and a follow-up observation from our experimental or intervention state, and we have a baseline and follow-up observation from our comparison state. And notice I underlined the C in this case to indicate that it's a comparison state, not a control group. If this was a control group, we would indicate it with a C, but not underlined. Okay? So let's assume that O3, our baseline observation in the comparison state, was also 50. Oh well, 50 per 1,000. So the two states were equivalent at baseline. And the low birth weight rate in the comparison state in 2022 was 45 per 1,000. What can we conclude at this point? And notice in the comparison state, we did not put an X here because we did not deliver our intervention there. Again, there might have been a national intervention that affected both states, right? Or a regional intervention for the Southeast that affected both states. But our intervention X was not delivered in the comparison state. Okay. What can we conclude in this case?
That the improvement wasn't completely due to our intervention.
Yeah, speak up.
That the improvement in rates wasn't solely based on our intervention.
That the improvement in the low birth weight rate in Tennessee was not solely due to our intervention, right? We can actually attribute how much of the decline in low birth weight rate in Tennessee we can attribute to our intervention? 5 per 1,000, right? Because in the state that did not receive our intervention, there was a decline from 50 to 45,000 without our efforts. Okay, due again to whatever was happening in the national or regional environment at that time. So this decline of 10 per 1,000 in Tennessee, part of it can be attributed to our initiative, and part of it is likely due to whatever else was happening in the environment during that time period. Okay? So this design that we have up here, where we have a comparison group and we collect baseline and follow-up observations from both groups, is called the non-equivalent comparison group design. Because we have a comparison group, it's not 100% equivalent to the experimental group, again because it was not established by randomization, it was established by matching. And this is a quasi-experimental design. So again, unlike the one group pre-test, post-test, which was a non-experimental design, this is a quasi-experimental design, meaning, again, it's not an experimental design where we have randomization. It's quasi-experimental, it's as close as we can get to an experimental design given the conditions that we have. Okay. So this design, again, it's not the gold standard, it's not a perfect design, but it is an acceptable design when randomization is not possible due to ethical factors or logistical considerations. What's important is that you select a comparison group, again, that is as equivalent as possible to your experimental group at baseline, so you're not starting with apples and oranges. And this design does offer some control over history bias. Not full control, but some control, which increases the validity of the findings relative to the non-experimental design that we reviewed earlier. Now, what if we are not able to identify an appropriate comparison group? And this can happen, right? What if we're not able to find a group that is, similar at baseline, again, where the likelihood of contamination, as was mentioned, is low? What do we do in that case if we're not able to identify a comparison group? Do we go back to the one group pre-test, post-test? And if not, how can we improve on the one group pre-test, post-test? If we are not able to identify, yes, ma'am.
So you can look at trends in the low birth rate before 2015, before the initiative.
Exactly. So if you're not able to identify an appropriate comparison group, you can look at trends. Exactly. And I heard here the term time series. So we can utilize a time series design where we include additional observations, right? Not just one pre-test and one post-test. So we'll have 2015, 2016, 2017, then we'll deliver the intervention. Then, in addition to 2022, at the end of the intervention, we continue to collect data in 2023, 2024. So we can have multiple observations before and after. O1, O2, O3, then intervention, then O4, O5, O6. Okay? So this becomes a time series design, which is also a quasi-experimental design. In the absence of a comparison group, this design allows us to look at trends, as was mentioned, comparing multiple observations before and after the intervention. So what we're hoping to see here is that for observations 1, 2, and 3, the low birth weight rate remains consistent at about 50 per 1,000, so there's little to no change over time before the intervention, and then we implement the intervention. We're hoping to see a drop to 40 per 1,000, and we're hoping to see this drop sustained over time in O5 and O6. Okay. So again, this gives us some assurance that this observed decline is due to our intervention, because there was no change over multiple years before the initiative until the initiative was implemented. Then we saw a decline, and this decline was sustained over time. Okay? Again, not a perfect design, but if we're not able to randomize and if we're not able to identify a comparison group, then this design becomes our best bet. Which goes back to the question that I was asked earlier. How do we select those designs? We select the best one possible given the constraints that we're working under. If we can randomize, we randomize. If we can't randomize, we select a comparison group. If we can't find an appropriate comparison group, we go to a time series design. Okay? Now the time series design itself, if we're able to find a comparison group, you can combine the time series design with a comparison group. So we can include our, let's say, Alabama here, if it's an appropriate comparison group to Tennessee, and also collect multiple observations from Alabama not deliver an intervention in Alabama, and then do O10, O11, O12. So this design that combines a time series or multiple observations with a comparison group is called the multiple time series design. Okay. It's also a quasi-experimental design, but this one is stronger than the non-equivalent comparison group and the time series. Why? Because it contains the good features from both of those designs. It contains the comparison group, and it contains multiple data points before and after. Okay? So really the multiple time series design is a combination of the time series design and the non-equivalent comparison group. Now let me ask you this question. those designs that include multiple observations before and after, do they work better if you are using secondary data that is available to you from surveillance or national surveys, or do they work better if you're collecting your own data? They work better if you're using secondary data. Because the cost to your intervention of collecting 12 data points in this case and high quality data will be very prohibitive. Okay? So the time series design and the multiple time series really work best, again, if you're able to utilize existing secondary data like low birth weight or mortality data that are regularly collected by other entities.
So what about historical bias on those secondary data? I mean, some things might have occurred during a particular year, like a recession, leading to something else. You know, how do you control for that?
So, if I understand your question correctly, what if the data that we want are not available?
No, I mean, the secondary data is available.
Yeah.
But let's say you're collecting the data for maybe 2009, for example.
Mm-hmm. It's not available that far.
Yeah, it is available, but you know, the observation that you're getting based on that year might have been, you know, biased due to a certain, you know, incident during that year.
Recession. So how do you control for historical bias in secondary data?
How do you control for historical bias in secondary data? By including a comparison group. So again, on the surveillance data and say data from the behavioral risk factor surveillance system or the CDC or the WHO or the Pan American Health Organization, right? It's not perfect data, but it's actually the best that's available to us. For us to go back and recreate that data may not, be feasible. So we recognize what we need to do is recognize its limitations, again, in our analysis, and to the extent possible, utilize it if it's a cost-effective way of doing things. Because collecting primary data is very, very, very expensive. Now, sometimes for our process objectives, we have to collect primary data because it's not going to be available, like the knowledge levels of our target population, their aptitudes. That's not going to be available typically. But for many of our impact and outcome objectives, we should see if the data are available from existing sources and utilize it where possible. You look like you have a question.
I do.
I see it on your face.
I guess, could you speak to what characteristics make it a quasi-experimental and what could push it one way or the other?
Exactly. So really, to call a design an experimental design, it has to be established, the control group has to be established by randomization. Okay, unless that condition is met, we cannot call a design an experimental design. Okay? The only experimental design, true experimental design, is where the control group is established by random allocation. How does that work? That works if, for example, you are my priority population, all of the students here in this class, okay? And we want to evaluate, our intervention is a new teaching approach, a flipped classroom design. we randomly allocate half of you to the intervention group that will receive instruction using the flipped classroom design, and we allocate the other half of you to the standard or the current instructional design. You don't get to select yourselves what group you want to go into. Okay? We use a random computer generator or some other randomization method, again, to randomly allocate you into the experimental group or the control group. Let's say there's 40 of you in class here. Again, randomly 20 of you are allocated at the beginning of the semester to the experimental group. And we teach 5,500 to the experimental group using the flipped classroom approach. The other 20 of you stay in 116 with Dr. Beatty using the current approach. You become the control group. The 20 who go into room 134 with Dr. Patrick Brown, who's our expert in flipped classroom designs, become the experimental group. So you don't choose what classroom you go into. We don't choose either. I don't get to pick, my favorite students to stay here and the other students go to Patrick. You're randomly allocated to both classrooms, right? So the probability, what do we mean by randomization? The probability of you have the same probability of being in the experimental group or in the control group, right? The same probability. That's the key. What randomization ensures is that the two groups are equivalent at baseline. Right? That's why the quasi-experimental design is called non-equivalent, because it's established by matching the comparison group, not by randomization. So if we randomly allocate the experimental and control group will be equivalent at baseline, again, if we do the randomization correctly. So your O1 and O2 at baseline, those two observations, will be very close, if not exactly the same. Then the experimental group again receives the intervention. So in this case, Dr. Brown's classroom will be the intervention group. Dr. Beatty's classroom will be the control group. We give you a pre-test of your knowledge of concepts of health administration and policy at the beginning of the semester on August 15 before classes start. Both the groups receive the same assessment and are scored. Then at the end of the semester, we administer the same test to both groups. And we compare the scores of the experimental group, Dr. Brown's group, to the scores of the control group. Okay? And if we see that let's say at baseline O1, O2 were 60, both groups, they scored 60 on the baseline test. Then the experimental group, they scored 90 on average. The control group, they scored 80 on average. Okay. Then we can conclude for certain in that case that the intervention method of instruction was more effective in increasing students' knowledge of the subject matter relative to the current method. So this is an experimental design. This is the randomized pre-test, post-test. This is the gold standard when we are developing new drugs, prescription drugs, not recreational drugs. When we're developing new prescription drugs, when we are developing new medical equipment, okay? When we are developing new public health initiatives on a small scale, this is the gold standard. We establish our groups by randomization. Okay? Only then, if those R's are here, it's an experimental design. If the R's are not there, it is not an experimental design, and will never be. Okay? Again, this is the gold standard, but in many cases, it's not feasible to implement this evaluation design in a real-world scenario. Again, for ethical or for other reasons. So then we see if we can do a quasi-experimental design, and our goal would be to select the most effective, the most valid quasi-experimental design that we can. Now, this is not to say, again, that the non-experimental design, like the one group pretest, post-test, is not an option. It is an option for short-term initiatives primarily and for process objectives. Questions? I know this is a lot. I told you it was going to be a crash course. Again, as long as you understand the key concepts, you can build on them. And you're going to have a chance to work on this for your project. Again, for your project, you will be developing 4 objectives: outcome, impact, and 2 process objectives. And for each one of those objectives, you will propose an evaluation plan with an appropriate evaluation design and data sources. Okay? This nomenclature, the O's and the E's, the R's and the X's, that's the Campbell's evaluation language after Mr. Campbell, who created really this approach to presenting evaluation designs. Any questions, folks? Yes.
I just had a clarification about this non-equivalent comparison group.
Say that again, please.
Is it called non-equivalent comparison group? So is it non-equivalent because there's no randomization?
Yes. You got it.
But I had to make sure.
Well, that's good. That's what we're here for. Other questions, comments, thoughts? No? Are you sure? Okay, well, if you think of any, again, email them, to me or to Dr. Beatty, and again, please get started, on your projects as soon as possible. Yes. Thank you, folks.